செக் டெஸ்ட் இருங்க செக் செக்
Check, mic check, testing. Check, 1, 2. Sound check, test, check.
செக்
Good evening, all. A very warm welcome on behalf of MST. Immunotherapy has revolutionized the cancer care in the advanced setting, but when it comes to the curative setting, the role of immunotherapy is still evolving, and it's very, very critical. All the MDT, they discuss the science and they see that the practical use of immunotherapy in the curative setting. So for that, we have this focused meeting focusing on the role of immunotherapy and breast cancer. And it's our honor that we are able to collaborate with ISO and especially Dr. Arvind Krishnamurthy in the capacity of Secretary of the Indian Society of Oncology. Definitely, Dr. Arvind sir does not need any introduction, professor of Adyar Surgical Oncology Department, and I would like to welcome sir for introducing our faculty for the today's meeting. Sir, over to you.
Yeah, thank you, Sujita, and warm welcome everybody who are here. I think who are trickling in slowly. I think there's a lot of traffic, and also to the more than 140 people who are actually waiting online. My apologies to the people who are waiting online, no, because we were supposed to start off at 7, but for some unfortunate reasons, we're just getting mildly delayed. I'm so happy to be here today. On a personal capacity and also as capacity from the Indian Society of Oncology. We've been in touch with the MSD, and we've been doing one program. So in the earlier program we had done at Delhi on lung cancers, and we proposed to do about at least 4 more meetings across the country. So this is the roadmap, and this is the second sort of meeting with that we are doing it in Chennai, and happy to sort of be part of this. And as you all know that ISO is a multi-specialty team. We sort of try to get an MDT concept, the multidisciplinary board concept, across all subsites, because we feel that's the best way that cancers are treated. So the first meet was on lung cancers, focus on lung cancers, and this I thought, like in the broad interest, we would focus on breast cancers. And as Dr. Sucheta said, that the care is becoming multidisciplinary. A lot of excitement is there because of the fact that the systemic therapies are now in the realm of early cancers in the neoadjuvant space as well. So what was there in the metastatic space is now initially came to the adjuvant and now in the neoadjuvant space. And in fact, in many cancers, it's actually dramatically revolutionized the way we manage cancers. It was be it lung, now breast, and possibly in the future head neck cancers also. I think they're going to see a sea change in which the cancers are going to get managed. So today's theme is on breaking barriers in early triple negative phenotype. And breast cancers, there are about broadly 4 different types. And triple negative breast cancers has a special focus. It has a lot of high rates of TILs, high rate of tumor mutational burden, high rates of many other genetic abnormalities, high rates of BRCA also in this. And so that makes it attractive for immunotherapy to be a potential target. So that is something that we are trying to focus on, and we will try to see it from 2 different scenarios. So for the first talk, I'd like to invite Dr. Anita Ramesh. Madam, of course, is well-known, a senior medical oncologist from across the country. She is based out of Chennai. She is professor and head medical oncology at the Savita Medical Hospital, Savita University, Chennai. In addition, Madam is also a consultant medical and pediatric oncology at Apollo Specialty, Shankar Nethralaya, and the HCG Cancer Centers. She's also a visiting consultant at the Kaveri Hospitals, Chennai. And Madam also is a CEO and the managing trustee of the Freedom for Cancer Research and Relief Foundation, and she does enormous meetings and very, very academically inclined medical oncologist, I must say. I think she's one of the best people to speak across many of the subsites, and now she'll be giving us an introduction into breaking barriers in early triple negative breast cancer's immunotherapy towards a promising future. Over to you, Madam. Yeah.
Very good evening. Thanks, Dr. Arvind, and thanks to MSD ISO for having all of us here together. I welcome all the delegates joining online as well as offline today here. And as you know, just a brief introduction on the triple negative breast cancer, and that helps us to take you into the what are the areas of improvement in these cancers. So how do we break the barriers in these early triple negative immunotherapy, and what is the promise that we have in the future? So this is being supported by MSD, and that's the disclosure slide. Now, if there is any adverse reactions, yes, do report, please contact, that's the address given, and this is the formality which needs to be done. Now let's see what's the agenda like. We are going to talk on some of the aspects of this cancer. Like, first we'll go back and see why or what is the rationale of using this immunotherapy in these type of early triple negative. Why do we incline more and why we don't do for the other cancers? Then we are going to slowly move into adjuvant setting. Then we look into what are the recommendations, where to use it, and what are the biomarkers or predictive factors which guides us towards it. Now coming to the subsite, you know as well, it is one of the breast cancers which has a different type of response rate prognosis. And it almost 15 to 20% of the total cancer diagnosed in India as well as across the world. Yes, hormone receptor positive tumors, they are the maximum around 70-75, and the HER2 positive constitute 15 to 20% of the breast cancer. So that triple negative, in any 100 cases, remember around 15 to 20% we are all going to see this triple negative, which are, what does triple negative means? The ER negative, PR negative, as well as HER2 negative. The estimates of these triple negative breast cancer ranges between sites and region. Yes, all over the world, almost the figures are the same. And whether you see in the United States, you see in European countries and in Japan, in the advanced stage, it is less than 10%. Around stage 3, it is hovering around 15 to 20-25%. And in early stage, the incidence is very more. And we are also surprised to see almost 60% approximately across the globe, whether it's the Far East or Far West or the European continent. So it indicates there's high prevalence, and India, there are several reports of an early breast triple negative. Our rates can even go up to 31%. Survival. Let's see how these triple negative cancers do. Now, if you are triple negative, your survival is almost towards the end of the bar or the end of the chart, and that's the bar that what we are looking at, only 77% if you see on the 100% years of survival. Whereas the hormone receptor positives does definitely well, where the HER2 receptors with the advent of anti-HER2, their survival has almost reached at a very good level. Whereas the triple negative, we are yet to get into good biomarkers and good therapies to give us the same results. Again, a little bit of busy slide, but it shows you that it's an immunogenic cold tumor. And if you see the molecular pathology, I think there are around 4 to 6 subtypes to this triple negative breast cancer. Immune cold, immune hot, Claudin type, many of them are there. Immunologically rich, immunologically poor, and BRCAness of the tumor, all are a spectra. It is not that the all triple negatives do badly, but there is a subset of triple negative who does well, which we have not been able to identify. And there are triple negatives which occurs in younger individual, advanced cancer. They respond very well to chemotherapy and they do quite well. And as with the response rate, the disease also comes back. So the breast cancer has a less lymphocyte infiltration and lower levels of tumor mutational burden. And that's where the bar stands with the breast cancer, the neoantigens seen in the human cancers. Now, if you see the triple negative, which has the poorest of the prognosis, in stage 1, 2, 3, 4, the survival figures are in the top. And the hallmarks of these triple negative breast cancer, they do have tumor infiltrating lymphocytes and they have a high tumor mutational burden. And this helps you to make it more immunologic, and that's how the tumor, we have the graph over here, the picture, how the neoantigens, the drug delivery system, the immune mechanism which causes cell death. And it's a unique of all the breast cancers to have this type of immune-mediated mechanism. As I told you, it has a higher immunogenicity and has a potential subtype of effectively targeted by immunotherapy drugs. And that's the crux of today's discussion, whether we can make use of this particular molecular subtype for targeted immunological drugs. You look at the picture with the triple negative and the ER positive tumors. The triple negative has higher mutational burden, higher tumor burden, and other than any other subtypes, and they do produce tumor-specific antigens, and they induced immune responses. If you come to the second bit of the column, which says that it has a higher tumor-infiltrating lymphocyte expression and expresses intensity much, much higher than any other subtype of breast cancer. This sequencing, RNA sequencing data shows there's a greater expression of PD-L1, and that's one of the key things that what we are looking into, whether we can target these tumors with an immunotherapy drugs. And triple negative has a higher expression, and it is highly significant. So that gives us a little bit of a background why we are having the immunogenicity of these tumors and how are we going to utilize them in our subsequent therapy, the rationale of immunotherapy for these triple negative breast cancers. So if you see the keynote 355, which shows the efficacy of pembrolizumab in a metastatic setting, the drug got its approval in November with the chemotherapy 2020. It was in the locally recurrent, unresectable, metastatic, triple negative breast cancer. PD-L1 was positive with the CPS score greater than 10. It gave a progression-free survival ranging a difference around 4 to 5 months. It was around 9.7 months benefit. And if you see the graph, which is showing that the curves separating around 4 to 5 months of survival benefit. If you go for exploration of the immunotherapy in early breast cancers, pembrolizumab, atezolizumab, and durvalumab are the three drugs which are in the discussion for this type of tumor. Keynote is with pembrolizumab, the neotrip, IM Passion 031 and 000 are with the atezolizumab, and the durvalumab is the Geopar new. Okay, so we are going to see a little bit of these tumors, but if you see the pembrolizumab keynote 322 and with the pembrolizumab with the use of these drugs, so the intent to treat population had 64% to the 13%, and showing the 5-year event-free survival was almost 81.3% versus 72%. Though the OS data was immature, but then definitely it showed a benefit. Yes, atezolizumab is a competitor, but then yet to have with so much of data, and the event-free survival did not significantly improve in the intent to treat population. Now, we are going to move into how these drugs, we having heard how they can be used, what is the rationale of using, and how we can use these drugs for the treatment of neoadjuvant and an adjuvant setting. So that brings us to the consideration of the timing of the treatment options for early stage breast cancer. If you think about neoadjuvant, yes, it provides earliest opportunity to eradicate the micromets. It induces an induction, decreases the rate of the spread of the disease. And also at the end of 4 to 6 cycles, you do come to know what is the pathologic response of these tumors. And that may be an early indicator of prognosis. And in many tumors, early complete pathogenic response has given us an indication. Yes, these patients are going to do well and they are going to be long-term survivors. So it will guide us also the future treatment. We do have an option on armamentarium to use in an adjuvant setting, which allows the time for the fastest time to surgery. There is no risk of pre-surgical complications, enables longer duration after your surgery is over, and more flexible timing post-surgery provides you to recover. So these are some of the rationales which can be common for all the diseases. So, and there is a gray area which overlaps between them. These immunotherapy drugs might be more effective in the neoadjuvant setting than in the adjuvant setting. And if you see the micrometastasis, eradication of the immune equilibrium, and the immune escape, and the partial immunological escape, and the graph showing that the timing, optimization of the use of immunotherapy prior to surgery did show a much better response rate, cure rate, and it has a decline in the recurrence rate as shown in the diagram. So, whereas if you have an adjuvant, yes, you do have the suboptimal priming, but then definitely a neoadjuvant targeting of the drug is a more logical approach to these tumors. Okay, coming to the keynote 5-22, okay, which had an eligible patients which were newly diagnosed with triple negative. They were TC1, that's the early stage, node 1, node 2, T2 to 4 with node 0 disease, and their samples were all sent for molecular subtyping, particularly the PDL1, started with the routine treatment of choice, platinum, taxanes, and or docet epirubicin, that's the TAC protocol, doxorubicin or epirubicin, cyclophosphamide. Pembrolizumab was given 200 milligram 3 weekly, okay, and the other arm had placebo. And the pembrolizumab ran throughout the chemotherapy schedules. Surgery was done at the end of the neoadjuvant phase, and then the adjuvant phase, we just continued pembrolizumab for 1 to 9 cycles, that is 27 weeks of 200 milligram. And this neoadjuvant phase starts from the first neoadjuvant treatment and ends with the surgery. And the adjuvant state starts once the surgery is over. So the risk stratification factors or the stratification factors for prognosis was based on the nodal status, tumor size, and the platinum. And remember, it is one of the schedules where platinum has been used, and it's a very good drug for using in triple negative breast cancer, whether we have a BRCA of 1 or 2 in the tumor, triple negative is used, carboplatin is used. Now, if you see the baseline characteristic and intent to treat of these populations using whether with the pembrolizumab and the chemotherapy or the placebo arm, they are equally balanced on all sides in the intent to treat population. Coming to the prior analysis in the keynote 522, the primary PCR and the endpoint of the stage 1A1 and 1A2 is shown over here, and that is the early stage cancer of the triple negative. And over here, if you see the graph showing that 91.3 versus 80.3%, and that has a very, very significant p-value showing the first event-free survival analysis has been definitely of a significant value. So that tells us, gives us a clue, yes, these triple negative with the neoadjuvant therapy is always definitely showing an improvement in the survival. Let's see the updated event-free survival data, and we saw earlier, now it has been over here with 81% versus 72%, and the HR is 0.65, and the events as shown in the curve, showing again the curves did diverge even at the end of 16 months, showing there is a sustained survival benefit as the two curves flattens over a period of time. The ESMO 2024, the key secondary estimates of the overall survival. Again, it was seen that the two curves did diverge at the 60 months of survival, this thing that is, which is 5 years, and pembrolizumab did demonstrate a statistically significant improvement in the overall survival in the neoadjuvant setting with chemo rather than when it is being used as a single agent or in a combination with pembrolizumab not used. So particularly in the high-risk individual early stage breast cancer, it is quite judicious to add the pembrolizumab to the backbone chemotherapy, and you do see a definitely survival benefit. That's the 2025. After the completion of the study, the NCCN guidelines has got it into a recommendation which says that rather the pre-operative, which is the neoadjuvant setting of pembrolizumab with carboplatin, paclitaxel, followed by perioperative pembrolizumab plus cyclophosphamide, doxorubicin, and epirubicin. The proper TAC helps you, and then you continue, you do the surgery, and after that you continue pembrolizumab into 27 weeks. And that's has attained pre-neoadjuvant adjuvant category 1 approval in the NCCN guideline. So with the neoadjuvant drugs, to add pembrolizumab, you can add it with carboplatin taxol, you can add it with docetaxel or epirubicin and cyclophosphamide, do the surgery, and then continue with the pembrolizumab adjuvant. Neoadjuvant plus the adjuvant immunotherapy, including pembrolizumab, brings a sustained survival benefit irrespective of whether we have achieved a pathological response or not. So this tells you if you have had achieved a pathological response is the first graph on the top which you need to see, saying that there is a complete good response up to 90%. If you did not have a pathological response, even then the arm which had the pembrolizumab did give you up to 71.8% at 60 months. So that's the thing, whether we look into PCR, yes, it has improved the PCR, but irrespective of the PCR, the drug has done well, showing that it has all subtypes of triple negative, it did act. The neoadjuvant immunotherapy, including pembrolizumab, greatly reduced the distant recurrence and metastasis, and greater the RCB load, and the more marked is the reduction. And that's what you see over here, as shown in the figure RCB 0, 1, 2, and 3. Coming to the NSABP study, that is, I mentioned earlier, the Geopard Dusus, which is the phase 3 study, which looked into a placebo with carboplatin, and the drug over here is the atezolizumab. That's the only competitor as far as pembrolizumab is concerned, with the same chemo backbone of a carboplatin, and the Taxol and cyclophosphamide and they also looked into the overall survival, PCR, toxicity, and the event-free or the progression-free survival. And that's the schema, how they continued, again 12 weeks neoadjuvant. If you see the phase 1 data, the primary phase 3 results, the two curves are merging with each other after around 46 to 48 months. That's around 4 years of follow-up, where you see the event-free survival 85 with 81. Not much of difference. The curve does not separate so much, and we have not got a p-value which is less than 0.005. It's 0.08, telling you it yet to be proven, and it yet to have its impact to show, yes, they are doing a good job in improving survival. Again, this tells you about the PCR and the event-free survival, 4 years data, 93%, 70. Both the arms are hugging each other, whether you give the atezolizumab or you don't give the atezolizumab. Even the response rate with chemo and atezolizumab and chemo and the placebo, not much of difference, 60 and around 58%. So not very significant data, but data which has to be shown because it's one of the drugs which is used, but then it does not have the survival benefit, response rate, event-free survival, and progression-free survival. Again, that is the Geopard Dusus study with the atezolizumab, and the overall survival data is again not significant. There's no difference, and there's no significant p-value. Why it's being an immunotherapy and one immunotherapy did not act and the other one did act? So there are some reasons, yes, these are hypothetical, maybe possibility, different effects of the PD-L1. And we know that we don't have a proper biomarker in these instances, which will guide us which one to use. But yes, the differential effect on the PD-L1 and the use of KN522 compared with the PD-L1 atezolizumab in the JPAD study. Also the patient selection may be of this subgroup analysis, the node-positive patient or those with tumor more than 3 centimeters benefited more with the treatment. So there are many subtle differences in the study which might have brought us to a conclusion that that drug did not, and there may be companion difference, there may be difference in the PDL receptor. But at the end, it has failed to show any survival benefit. The IM patient 030 study, which is the adjuvant setting of immunotherapy, did not improve outcome in the intent to treat population and the PD-L1 positive patients. So the median follow-up was around 2 years, 25 months, and again you see both the curves, whether it is intent to treat population, all of them with the PD-L1 positive, there is not much of difference in these tumors. Let's come to point number 4 for our agenda. We need to clear the couch and see what's in the future. What are the recommendations in neoadjuvant and adjuvant setting, and what do we do with the residual disease? So let's go through a case. It's a late 99, left breast, 32 years she was, lumpectomy, had nodes positive. At that time it was an hormone receptor positive, standard of care given, tamoxifen 4 years. In relapses in a couple of years' time, BRCA mutation, prophylactic oophorectomy. No, that time did not relapse. We did the BRCA testing, 2011, pathogenic mutation, had prophylactic hysterectomy, bilateral oophorectomy, and was on follow-up. 2023, abnormal left mammogram, seen asymmetric density, suspicious of BIRATS 3 and 4, PET scan done, hypermetabolic breast, and with a ER negative, PR negative, HER2 negative, invasive cancer. What do you do to these patients over here? And then whether we proceed with bilateral mastectomy or followed by chemo plus pembrolizumab, or we give them 2 cycles of AC and then the paclitaxel with the carboplatin with the pembrolizumab. There's also another choice of giving of a neoadjuvant docetaxel with cyclophosphamide or docetaxel with carboplatin. Or give a neoadjuvant all the 3 drugs. What we saw in the neoadjuvant studies did show that yes to use of pembrolizumab with these drugs. Now, if you see the ASCO and the SSO updated BRCA testing guidelines, all patients diagnosed with breast cancer, if you are in the stage 1 to 3, de novo and metastatic stage 4, 65 younger, should be offered a testing with BRCA1 and 2. That's what the agreement says. If you see the recommendation modified with 1.2, newly diagnosed CA breast, stage 1 to 3, whether new, metastatic, older than 65 should be also offered for the testing, because we do have the drugs like PARP inhibitors which can be used, and early stage metastatic disease to have these. So going back to our patient over here, she was treated with docetaxel, carboplatin, pembrolizumab, given at the standard dose for 6 cycles. Continued response ultrasound at the end of 6 and the third 3 and the 6th cycle. Then had a MDT discussion where it was decided to take her up for surgery, and then underwent bilateral skin sparing mastectomy, and it was grade 3 tumor, 10% cellularity, 2.4 DCIS, negative margins, and markers were similar, which I already alluded, ER negative, PR negative, as well as HER2 negative. What do you do next to these patients? Yes, we have given them the platinum and the pembrolizumab, and the patient has got a good response. Do we continue pembrolizumab and capecitabine. Yes, now there is the data and all our practice, we have started continuing capecitabine maintenance 6 to 12 months for all high risk triple negative. So is that capecitabine applicable here? Do we continue pembrolizumab? Start olaparib because we know in 2011 she was BRCA positive. Stop the pembrolizumab and continue the targeting the mutation, or give 2 cycles of AC. So that's all the discussion that we need to do in our tumor board to give the lady the best chance. That's the Olympia study, which has a 3.5 years follow-up and showing that 72% BRCA1, 82% triple negative, 50% post-NSCT. There's no increase. We have the olaparib data, which says people are a little afraid that yes, there may be an increase in the MDS and AML over a period of time compared to the placebo. No, most of the toxicities were grade 1, grade 2, nausea was common, and anemia, yes, all olaparib patients receiving do have anemia and thrombocytopenia as well as fatigue. The neoadjuvant group, as alluded here, and the adjuvant group, and the neoadjuvant group had the non-PCR, and the adjuvant group as shown in the diagram. Adverse reactions in the neoadjuvant, adverse reaction, which was greater than 10% in the Olympia, and if you see the GI disorders, the fatigue, anemia, thrombocytopenia, leukopenia are very common, the nervous metabolic. These are common side effects which are there for the use of these drugs. Olaparib compared to placebo, and though it's an oral tablet and we have all used it and we know that there are toxicities and side effects, but it is not that an easy drug. If you go back to the NCCN guidelines of 2024, so that gives us the guidance in integrating chemoimmunotherapy in early stage triple negative breast cancer. So we are in research moving towards an immune-mediated neoadjuvant approach to these tumors, and stage 1 surgery, no chemo. And if you see the stage 2 to 3, yes, pembrolizumab is already included with the platinum and Taxols in the early part prior to surgery. So that's how we are moving into whether we can give them a greater benefit of pathological response rate and more better survival and remission with the use of incorporating immunotherapy upfront in these treatment. If these tumors, like our case, did have a mutation in the BRCA1 and 2, we added the olaparib, and that's the study where adjuvant pembrolizumab with olaparib to continue. If the patient did not have any BRCA mutation, yes, then you continue adjuvant pembrolizumab. We have started giving capecitabine for all my patients, okay, and that's whatever the data as on today permits, I do give capecitabine. The ESMO 2024 guidelines of adjuvant therapy consideration, and again, quite a busy slide with early tumors, which we are focusing for today's discussion. There is a definite role of use of pembrolizumab with the carboplatin, Taxols, cyclophosphamide, and the anthracyclines in the neoadjuvant setting. Yes, adjuvant setting, pembrolizumab is also being used, and if there is a BRCA in the tumor, you have to add olaparib. If there's no BRCA in the tumor, then you just can plus or minus capecitabine, and that's how it goes with the recommendation, and it's over here. Please do immune profiling of these tumors when they relapse upfront to see the BRCA1 and 2. If there is also some data of looking into the HRD, HRR testing, plus you can also see the PD-L1, CPS core, and the tumor mutational burden. So in this triple negative breast cancer, the adjuvant therapy, what happens to those patients who has not achieved a pathological complete remission? Yes, adjuvant capecitabine did improve survival. And can we add the immunotherapy to these drugs? And that's the curves showing there is benefit, progression-free, even-free survival benefit. And the curves did separate, giving you a significant p-value. So that brings us to the adjuvant treatment consideration and the recommendations. And immunotherapy, should not be given solely as a single agent for adjuvant therapy without a prior neoadjuvant. Just can't start after the surgery has been over. You have to start initially, plan it properly, give it in the neoadjuvant, and then continue in the adjuvant setting. Point number 2, if the patient is having a germline BRCA mutation 1 and 2 and high risk for triple negative breast cancers, patient has not achieved a pathological remission or a pathological stage of 1 to or 2 to 3. 1 year of adjuvant olaparib is the recommended therapy for this type of patients. The combination of immunotherapy and olaparib may be considered on an individual basis. Remember, this may be financially toxic, but then if other logistics are not in place, you have used immunotherapy, you have got a good response, so if logistics in place, please continue. Patients with residual disease, what do we do? Not everybody will get into a complete remission. So in these patients who have not who did not receive an immunotherapy should be offered just adjuvant capecitabine, and that's it. You should not go back and start immunotherapy at that point of time. The combination of olaparib and capecitabine again should not be used in a germline mutated. Don't use the capecitabine, just continue olaparib adjuvant. The combination of immunotherapy and capecitabine, again use it. It may not be very financially toxic, but yes, you have to see the patient and use it. Coming to the follow-up, what happened to this patient? We continued pembrolizumab. We started olaparib 300 milligram twice daily because our patient was BRCA positive in 2011. Patient did have anorexia, fatigue, bloating, and restarted on this, had some rashes, and we sometimes reduce the dose, sometimes we give a gap holiday, and I have even come up to 150 milligram BD olaparib for these patients. Then quickly, before we finish, couple of slides, the role of adjuvant pembrolizumab in patients with early breast cancer and those who have really achieved the pathological PCR. So we look into the event-free survival in the overall subgroup of patient, and we see it by this tumor size Y. And this tells us the event-free survival in patient with complete pathological remission with the use of pembrolizumab is much better, and they have the percentage of patients achieve PCR without the immunotherapy. So definitely the immunotherapy has brought many patients into the purview of a negative complete remission or negative pathology. Persistent risk factors recurrence after the PCR in 5 to 10% of the patients were seen. And the long-term results will tell us the data for the adjuvant immunotherapy. And that brings us to the last agenda of today's talk, the role of biomarkers. Already we have alluded earlier, this particular tumor, we do not have much of the robust biomarkers or immunological markers which will guide us both prognostic as well as predictive. We need precision oncology, and we are more looking into, and the research is still going on, and yes, we have to get something. The PD-L1 status is that's what we use regularly with the CPS score and TMB, tumor mutational burden. PD-L1 status cannot accurately tell us or predict the efficacy of the immunotherapy in these early stage cancers. And you see the KN522, the IM passion with the atezolizumab, all of these immunological studies were unable to tell us, yes, whether this can be used as a marker. The value of the tumor-infiltrating lymphocytes. These tumor-infiltrating lymphocytes have shown in many studies, which gives you a clue, yes, these tumors are immune-mediated. Yes, my immunotherapy will act. Can I see the TILs? And I think many of the pathologists have started reporting TILs in the tumor. So higher PCR rate in TIL-enriched tumor treated with chemo did show some benefit. The change of the TILs between baseline and after the window significantly predicted that these patients, the immunological response will be better, and a better complete pathological remission was seen when particularly a study with the durvalumab. Pooled analysis shows that in early stage of triple negative breast cancer, who has a higher tumor infiltrating lymphocyte had a better disease-free survival and an overall survival. So all this gives us a trend and a bit of leap towards look into these tumors. They might guide you, yes, these tumors are immunological in nature and I can use an immunotherapy. More biomarkers from what we saw. Potential predictors of precision oncology and precision therapy. The GPAR-NEO, which we also discussed, and the gene expression profiling, and the NeoPact, the positive, had significant predictor had. So there was small difference in the bar chart, but then nothing to tell, yes, this is the marker and we want to go for it. Looking into the circulating DNA or the circulating the ctDNA, that is the significance of ctDNA in triple negative and retrieving those who are getting into the neoadjuvant therapy. And the PCR versus, this has been shown in the tumor, and again, early clearance of the circulating DNA did predict a good survival, but ctDNA negativity associated with an improved cervical even despite having a residual disease. So even if you had a residual disease, the clearing in the blood gave you an indication, yes, the surgical outcomes are going to be better and with my immunotherapy. So this is few of the points that we wanted to bring today. So quickly we'll summarize the slides and end the talk for tonight. A higher immunogenicity in the triple negative breast cancer exhibits a higher mutational burden, high risks, high increase in the TILs level, and significantly greater PD-L1 gene expression. There are subtypes and highlighting the potential use of effective immunological agent. Remember, triple negative has 5 or 6 subtypes, and there are these immunological subtypes. If you are able to pick them up by these biomarkers, they are the targeted tumors who will really do well with the use of immunotherapy. The guidelines for recommendation, both the NCCN updated 2025 and the ESMO guidelines highlight immunochemotherapy for early stage neoadjuvant treatment for triple negative breast cancer. When do you treat? The timing of the treatment. The neoadjuvant immunotherapy is more effective, so start it early before the patient goes for surgery and then continue it with the adjuvant therapy. The post-neoadjuvant treatment strategies, the residual disease will tell you after the neoadjuvant immunotherapy or suppose if you have a residual disease, you had used immunotherapy, please continue immunotherapy. You can add plus or minus capecitabine. If you have not used immunotherapy, just continue capecitabine with the residual disease. Please don't forget to check the BRCA-ness of the tumor, BRCA1 and 2, because if the tumor has any of these BRCA-ness, then olaparib comes into the setting and the drug needs to be used because mutation needs to be targeted. Biomarkers, we are all going into continuous research to see what particular, these drugs are expensive, so we need to know whether they are going to really act on the patients. So continuous investigation of novel biomarkers and the best paired neoadjuvant and adjuvant therapies so that we get the maximum benefit and use this drug judiciously to get the best benefit and minimum toxicity. And I think, yes, we need to discuss with the logistics with everybody before you start, but definitely it is one of the very, very good steps with the PAP program in place in India. Many patients are getting benefited, and that's the way to go forward. And I thank everybody, and now I realize why my talk was before the surgeon, because we have to start before you do the surgery. Thank you, doctor. Please, we are waiting for you.
Yeah, thank you, madam, for that thing. No, I think the true MDT concept is there. So I guess now what is happening is neoadjuvant immunotherapy is the flavor. That's why your talk was first, madam. I think. So I think I'll just briefly introduce Dr. Vijay. Sir is a colleague and a friend or sorts. I must say, though he's much senior to me. I think I've Almost the second place after TMH I visit is Ahmedabad and to their cancer center. In fact, I was supposed to be in Ahmedabad last weekend also for a meet, but I think one of our residents got married, so I said like I'm not coming. So I think, but I think they have one of a very good cancer centers in HCG Ahmedabad. I know the entire team there; they're doing wonderful work. Sir is represents the breast division there. And he's the president of the APSI, that is the Association of Breast Surgeons of India. So when MSD wanted me to sort of choose a choice for the surgeon, I said no better than Dr. D.G. Vijay. So I think we are all fortunate to have, of course, all of us here, and of course I think 162 odd people are there online. So I'm sure that everybody is waiting for your talk, sir. Over to you, and then we'll have the discussion. Thank you, sir.
Good evening, friends. I completely apologize for starting the meeting late, but it was the flight from Ahmedabad took off late, and then sequentially we live in a state of suspension of disbelief where we do not accept that. I thought that the flight took off late, but it will land on time because that's what the pilot told us, and then I did not at any point of time think it appropriate to call Arvind and tell him that probably the meeting might get delayed. So only two things can drag me to Chennai on the Valentine's weekend is Arvind Krishnamurthy and the beautiful city of Chennai. I am here on the invitation of MSD, of course, but there is a small story that I would like to tell you. For those of you who read Medscape Oncology, today's post is about a physician in the US. As Dr. Anita Ramesh rightly pointed out, that this drug has a lot of excellent results, but at the same time it also comes with a lot of side effects as well. So it's really about knowing which patients, that is where her expertise lies, in which patients to use this drug appropriately, and who are the most likely candidates who are likely to benefit from this particular treatment. So what this Medscape Oncology article says is that there are research going on by Dr. Koch in Netherlands, who said that some small studies, most patients with stage 2, stage 3 triple negative breast cancer who achieve a PATH-CR and have TILs, which are tumor infiltrating lymphocytes, over 30% after anthracycline-free neoadjuvant chemotherapy live at least 5 years. So they measured sequentially the TILs in these patients after 4 cycles and various cycles, and eventually patients who achieve PCR and have, which is exactly what I'm repeating what she said, but that gives us an insight into how immune driven we are gradually going towards the treatment of breast cancer. And in fact, there are 2 very large phase 3 trials called Optimize PCR and Scarlet, which are studying biomarkers in triple negative breast cancer to specifically identify a subset of patients who will certainly benefit from neoadjuvant pembrolizumab. It's also very important to know who are the patients who are going to receive pembrolizumab in the adjuvant setting. It cannot be that all patients. So that is where background I come from. The reason why I'm here is because we have used, this is our data from triple negative breast cancer. So we quickly put in some numbers, and 232 patients of triple negative over the past few years who received, triple negative patients who received neoadjuvant chemotherapy, out of which 75% achieved a PATH-CR. If you can't see it from the back, I would request some of you to come up front. Initially, as you all know, we used to use an AC plus paclitaxel. In that case, the PATH-CR rates was about 27%. When we started adding carboplatin, thanks to the brightness and the work done by Dr. Sudeep Gupta and his publication, and then it became common sense to add carboplatin in these patients, the response rate went up to 38%, so 21 out of 58. And then when pembrolizumab eventually kicked in, and that is in about 19 patients, so we have about 11 patients, so 57.89. If you see the Keynote 522 data, their PATH-CR rates are 60 to 65%, but obviously this is a very bad subset. These are basically locally advanced breast cancer practically inoperable T3, T4, N2, N3 disease in whom triple negative. So all negative, in spite of that, getting a PATH CR rate of about 57, I would say the drug seems to be working. In India, triple negative breast cancer is present in about 25 to 30% of all Indian patients. Obviously, they come with higher grade and rapid growth, more advanced disease. TNBC primarily affects younger patients, less than 50 years of age, with 20% harboring a BRCA mutation. And as we all know, it follows an entirely different life cycle, and there is early recurrence within the first 3 years, mainly involving the lung, liver, and the brain. As you can see here, can I have this pointer? As you can see here, the crowding of the recurrences for triple negative breast cancer will take place in the first 3 years. So if an average patient is surviving for the first 3 years after triple negative breast cancer, then the graph falls off, and eventually over 5 to 6 years, it comes very close to the baseline. So all these criteria show that triple negative breast cancer meets an unmet clinical challenge due to its worst disease-specific outcomes compared with other breast cancer subtypes. Obviously, for HER2 positive, we have a lot of drugs. For hormone receptor, of course, the prognosis is much better. And as you can see, the survival rates for triple negative versus other breast cancer is completely different. So this is practically the same slide again, the rates of distant recurrences following surgery in triple negative, again in the first 3 years, and hazard functions for death among patients who have triple negative is significantly higher in patients who have triple negative breast cancer. Unfortunately, many of them also have visceral metastasis, lung, liver, brain, very less often bone. Again, hormone receptor would have a lot of bone metastasis at metastatic, if they are advanced diseases, and the death rates are highest in the first 3 years of diagnosis. And this is a table which shows that basically patients who are triple negative have a much higher significant proportion of visceral metastasis. So the treatment has to be based neoadjuvant, which Dr. Anita Ramesh was talking about. We have had a paradigm shift in the treatment of locally advanced breast cancer. One of the reasons is that for patients who did not achieve a PATH CR, we have a lot of effective adjuvant treatment. So surgeons who are very gung-ho about operating all node positive patients, and we are very scientific in our approach, Arvind and I and many other surgeons. So we have shifted because we are open to these sort of the new knowledge that comes in. Create-X, which Madam talked about for in the use of capecitabine, and Olympia for olaparib for BRCA mutation patients. What neoadjuvant therapy does for surgeons is that it significantly downstage the disease. You know, the nodal burden in India is very, very high. Sometimes you have shocking reports of 6, 8, 12, 14 lymph node positive. So many of these patients, when you operate upfront, you are likely to have a very high nodal burden positivity. It also does tumor, not downstaging, but at least downsizing of the tumor takes place because of these patients. So before, this is the pre-K-Note 522 era, where tumors up to 1.5 to 2.5, we used to do surgery first and then give them adjuvant. For larger tumors, we were considering, based on the NSABP trials, neoadjuvant dose-dense anthracycline with taxanes. For patients who achieved a PATH CR, no systemic treatment. For patients with residual disease, as you heard, capecitabine. These are all triple negative breast cancer patients, and who are BRCA mutations, we used to give them olaparib. What happened after Keynote 522 is we have incorporated the use of pembrolizumab in many of these patients. Of course, for smaller patients, we would still consider upfront surgery even in triple negative. So any tumor, let not the audience go away with the impression that all patients, so if the patient is probably amenable to a breast conservation surgery today, for a tumor which might be, a little controversial, between 2.5 to 3 centimeters, but certainly up to 2, we would certainly go ahead and do a breast conservation surgery and then give her in the neoadjuvant setting. But if the patient wants a breast conservation and the tumor to breast ratio is not appropriate, we would probably give her neoadjuvant, downsize the tumor and then operate. So that is what this slide basically talks about, incorporating the use of pembrolizumab in these patients. If anthracycline is contraindicated, then taxane with carboplatin. The indications of neoadjuvant chemotherapy are very clear. They remain the same, whether it is locally advanced breast cancer, T3, T4 tumors, N2, N3 disease. We want to convert some patients in India. We see a lot of advanced inoperable inflammatory breast cancer to convert from mastectomy to breast conservation surgery and to improve the outcomes. For those in the surgeons in the audience, for HER2 positive breast cancer, in whom we use Fesgo or pertuzumab, trastuzumab combinations, or triple negative breast cancer, in whom we use pembrolizumab, nearly 60% of patients are likely to have PAT-CR. So, if you have clipped the tumor and you just do a sort of a clipectomy, just remove a small area around the clip, the margins really don't matter because all the disease has gone away. So, it not only reduces the volume of excision for surgeons, but the margins don't matter because in nearly 60% of patients, all the tumor seems to have gone away, whether it is triple negative breast cancer in whom you have added pembrolizumab or HER2 positive breast cancer in which you have added trastuzumab, pertuzumab, either the subcutaneous preparation or the intravenous preparation. So it's a great advantage for surgeons. Of course, it de-escalates axillary surgery. Again, for the surgeons in the audience, let me clarify. For N2, N3 disease, we still continue to do a axillary lymph node dissection. It is only patients who are N1 prior to initiation of neoadjuvant chemotherapy, after we add NACT at the completion, and if they convert into N0, and if you are following a protocol of doing sentinel lymph node biopsy post NACT, then we will consider them for sentinel lymph node biopsy. The criteria are a little more stringent for doing post NACT SLNB than for doing pre NACT SLNB in the form of using a dual dye and harvesting at least 3 nodes. It gives us time for gene testing and it facilitates more complex surgery. I think the case that Dr. Ramesh showed, the patient underwent a bilateral skin sparing mastectomy and probably a bilateral reconstruction, either with the help of implants, most probably with the help of implants, because doing a bilateral tissue-based reconstruction would really be very, very challenging. All the guidelines for triple negative breast cancer, whether it is NCCN, ESMO, or AGO, or the St. Gallen, they all say that some form of dose-dense anthracycline, taxane, and adding pembrolizumab is the current standard of care. The question is which patients benefit most from immunotherapy, whether it's based on tumor burden, nodal status, or biomarkers like I mentioned in the beginning of my talk. The keynote 522 trial design, so patients were randomized 2:1, pembrolizumab 784, placebo 390 patients. They were subjected to carboplatin, paclitaxel, and doxorubicin or epirubicin with cyclophosphamide. This is the schema for the particular trial, and pembrolizumab was given 200 milligram every 3 weeks. And the other arm, of course, had placebo in the second arm, and they underwent surgery at the completion of the cycles. And they continued pembrolizumab in the adjuvant setting and placebo in the adjuvant setting from 1 to 9 cycles, 27 weeks. The question is there a cutoff of the size beyond which you would give neoadjuvant chemotherapy for triple negative patients? The ISMO currently recommends NACT, including pembrolizumab, for patients. Any patient who would require chemo, neoadjuvant chemotherapy is likely to benefit from the inclusion of pembrolizumab in these patients. Having said that, there is a need for, in our setting, wisely choosing patients, because my first slide started with using only dose-dense AC plus taxane, AC plus carboplatin, and that. So it's really a balancing, triaging these patients of triple negative patients into these 3 slots. So both for tumors larger than 2 centimeters, today we would offer neoadjuvant chemotherapy with or without addition of pembrolizumab. Whether nodal positivity in early breast state. So as the size of the tumor increases from T1A-B, nodal involvement is 9.4%, T1C 14.9, 15%, and T2 will have nearly 20%. So as the size of the tumor increases, the nodal positivity will increase, and therefore that is a primary reason why we want to give. So any patient who is likely to have more than 10 and approximately 20% nodal positivity, we would certainly want to give neoadjuvant chemotherapy with or without pembrolizumab. Pre-treatment axillary USG and biopsy can identify these patients and should be considered in patients presenting with triple negative breast cancer more than one to inform preoperative immunotherapy considerations. So whether the HER2 among patients with early triple negative breast cancer treated with neoadjuvant chemotherapy, because there is this whole new subset that we have created of HER2 low. So even if there is a HER2 low status that was not associated with PAT-CR or overall survival rates after adjusting. So it doesn't matter if it was HER2 was negative or low. This is again something that Madam I think talked about, but PCR according to the disease status, stage 2A, the PAT-CR rates go up to about 73% versus 62% if you are using a placebo. Again, 2B, 3A, across all stages you can see, starting from 2A to 3B, the PAT-CR rates are much higher when you add pembrolizumab to chemotherapy in these patients. Again, neoadjuvant setting combination, basically the same thing for event-free survival. For stage 2 and for stage 3, there is a difference in the outcomes when we add pembrolizumab versus using a placebo alone. This is overall survival for stage 2, stage 3. This is something that we must discuss with patients, that what is the difference between event-free survival and what will be the difference in the overall survival when we use an expensive drug in an Indian setting. As you can see, that graph is much narrower, but if the patient can afford and wants to use pembrolizumab in a neoadjuvant setting, there is certainly that window of opportunity that we have in using pembrolizumab in these appropriately timed patients. Whether nodal status is the only point on which we can decide for checkpoint inhibitors, the answer is no. So whether it was node negative, also we saw benefit for node positive patients, also the benefit across this subset of patients. So as you can see in that plot, for both these node negative and node positive patients benefited from the use of pembrolizumab in the neoadjuvant setting. And again, the overall survival, as you can see, these are the things that we need to discuss in greater detail with patients. Now, whether in patients with smaller tumor burden, so whether it was stage 2 or stage 3, did it make a difference? Again, in T2 and 0, across all subsets, I think the plot is in favor of using pembrolizumab, whether it was negative nodal status, smaller tumors. And many of these patients actually do not require a PD-L1 testing. No additional immunohistochemical stains are required. And irrespective of the PD-L1 expression, this was alluded to also by my former speaker, that across all subsets, the CPS score, the benefit of pembrolizumab was noted across all subset of these patients. Axillary dissection is probably one of the most morbid procedures that we have done, and gradually the morbidity of that has gone down significantly because of sentinel node biopsy. But management, this is what I think I spoke about in the beginning, where N2, N3 disease, we would certainly want to do a full axillary lymph node dissection only for patients who are, this is a good slide in the sense that pre-surgery, pre-NSCT and post-NSCT patients. And when would you do according to the Z11 and MROS trial, and it includes practically all the trials for the current management of the axilla. But however, having said that, for N2, N3 disease, a complete axillary lymph node dissections for those patients who become N0 and they had a low nodal burden prior to initiation of NSCT, you might consider doing a sentinel lymph node dissection. So this particular, I think in the keynote itself, 86% of node positive patients converted to N0 at definitive surgery and 67% achieved a PAT-CR. So pembrolizumab, NSE has significant oncologic benefit but noteworthy perioperative considerations in the surgical management. So a lot of patients, the tumor becomes smaller, the nodal burden goes down, but please remember that the nodal burden that they have in this subset of patients would be much lower. But even then, in a very, very small pilot study of our 19 patients showed that about 57-58% of patients would still undergo a PAT-CR. I think this is basically the data from the same thing, that breast conserving surgery and placebo. So similar results. Ideally, in a neoadjuvant setting, we would prefer to do surgery around 15 days once the counts recover. However, in these patients, the average duration of surgery is around 1.2 months. Between the last cycle of chemo, it takes them that much amount of time to recover from the side effects of this chemotherapy plus pembrolizumab. However, there is no increase of surgical complications in the patients that were studied. Again, adjuvant RT for these subset of patients, sequential or concurrent RT, these are some of the things that are being studied in the keynote 522. Sequential RT is the last adjuvant RT exposure was before the first dose of adjuvant. So the adjuvant is completed and then RT. And sometimes the RT can run together along with the pembrolizumab. I think for the sake of time, we can skip some of the radiation slides. Did you speak about the monitoring for? So we have to monitor them for immune-related adverse events. We are taking the benefit of the immune-modulated checkpoint inhibitors. So again, there are across the whole body, there will be a lot of side effects that could be impact all organ systems, could be severe, life-threatening, permanent, different from toxicity. You know, conventionally we are thinking of chemo-related side effects, but as you can see in that particular slide, a very busy slide, the immune-related toxicity are significantly different from the toxicity that are attributed to chemotherapy. And the time course is also highly variable. And the various side effects appear at various times. So whether it is colitis, endocrinopathy, nephritis, thyroid functions go down, the liver toxicity, the skin rash or pruritus, they will all appear at various points of time. And the endocrinopathies, so we need to monitor TSH. So when you take these patients for surgery, you need to do a serum TSH and make sure that their cortisol levels are also. So it can affect the thyroid and the adrenal gland, and we need to make sure that their cortisol levels and TSH levels are normal. So it's a list of the major complications that can, side effects that can occur from these drugs. And monitoring for immune related, so they should be, so the monitoring of this has to be standardized. Surgeons should know about the symptoms of immune-related adverse side effects, and surgeons are responsible to ensure that thyroid and adrenal gland functions, which is the cortisol that is shown here, they are normal, not only before surgery for the safety of the anesthesia, But also in the post-operative setting, these have to be constantly monitored. So appropriate testing, if you feel that the anesthetist or the endocrinologist is better equipped to monitor them, or an intensivist or a physician, endocrinologist, normalize thyroid functions before surgery, and stress dose corticosteroids if necessary. That will be my last slide, and that is the new HCG Astha Cancer Center, and I bring greetings from that. So, as to summarize, pembrolizumab has added one more drug. So, when Arvind, he's not as young as he claims to be, but but there was only, we used to operate all these patients, node positive patients, we used to certainly offer them. So when neoadjuvant came, anthracycline taxane, then so it has, we are witness to this entire movement where we used to consider triple negative as a very, very bad disease, and we had very little options. So with these immune checkpoint inhibitors and more drugs in this particular field, and to look for responses, which patients will benefit. So it's opening up an entirely new field of research in triple negative breast cancer. So it's probably not going to be as bad a disease as it was in the past, and we will hopefully get better and better results. But ultimately, as president of ABSI, it's early detection and screening that's probably going to, awareness that is going to get in more early breast cancer patients for whom we will be able to give better and better results. Thank you very much.
So any questions from anybody in the audience? Yeah.
You have many. Oh, then you start. So thank you, doctor, for a good talk. And just to add of it, like in HER2 tumors, from very small tumors, we have started giving the TCPH regime. So how small in your practice, you say, I will take it up for surgery, or you go ahead and give the neoadjuvant therapy? And secondly, wanted to know your role for clipping up the tumors prior we go for the neoadjuvant therapy.
I think if you go by the rule book, that the size is 2 centimeters. But if the patient is certainly going to go for a mastectomy, then I would sometimes, for tumors which are 3, 3.5, perform a modified radical mastectomy if she is not going to do a breast conservation, and put in a chemo port at the same time, which is a very practical way in a private setting, because that center is
you're right.
fairly expensive. So otherwise, if the patient is desirous of breast conservation surgery, I would put in a chemo port, give her 6 cycles of TCHP, and put in a clip. So putting in a clip is not always done at the first, whenever you see the patient first. You can do it at the first sitting, or you can see how she responds, and maybe after 2 cycles, when you do the ultrasound, you can probably put in the clip, which is also, many centers do that. So that is also because the 4.5, and it's a very, so maybe you could do it after 2 or 3 cycles, and then after response evaluation, then do the clipping.
What do you do for 0.5 centimeter tumor, 1 centimeter tumor, 1.5 centimeters tumor? You just do the surgery, or you have a discussion for neoadjuvant? You have got a 1 centimeter tumor.
No, I would not go for a discussion.
You will operate straight away.
Operate straight away.
0.5 also. But in the HER2, the scenario is changing. And just quickly to all of you, since we did not...
No, I would also want to know what is being done in Chennai, because what is Arvind?
No, you rightly said, up to 2 centimeters. That's what the guideline says. That because I remember an instance, I think it was an MST meeting in Singapore. So what they had done was, it was a 2.1 centimeter tumor, and a lot of them seem to sort of favor the neoadjuvant route, essentially. For them, guideline is sacrosanct. So even for a 2.1 centimeter, I just said like, maybe we could sort of, consider the upfront surgery. But I think that's where the world is moving. And that time it was, I think, Professor Gentilini, who was a major part of the keynote 522. She was sort of there, and many other people in the audience essentially. So that's the mindset of people abroad, for them, even a 2.1 centimeter. So as you said that we are not that much pro. Anything less than 2 centimeters, I think even majority of the guidelines say that you can operate first. But in fact, some of the guidelines say that more than 1 centimeter, because in triple negatives more than 5 millimeters patients have to give chemotherapy.
Yes, yes.
So
right.
I guess I think the world is
The number might change over a
number
period
might
of time.
change, but by and large 2 centimeter more is the guideline recommendation. But sometimes in the Indian setting we are a bit more flexible about 2 or 3 centimeters or something of that sort. But by and large the discussion on neoadjuvant comes at that time. Yeah.
Just one more comment to add to everybody. We saw all the immune-mediated thing. That is for a theoretical, what doctor has said. For theoretical, yes, we need to do. But in practice, immunotherapy is a very, very, very safe drug. We have minimum toxicity, and we are all aware of the toxicity. It is not that one has to be very afraid, and it is an acceptable toxicity. So I have given several cycles of pembrolizumab, and yes, nothing of an alert. It's a very safe drug. It's an easy go through. Only, yes, you have to tell what Sir said, that these are immune toxicity. Less than 5% gets toxicity. It's a very, very wonderful drug, pembrolizumab, minimum toxicity.
For the postgraduates, these are guidelines, not protocols, where you cannot violate them. So if the tumor is 2.1, you can send them back to the radiology department and ask another radiologist to do the ultrasound, because it's an observer-dependent finding, and he might report it as 220 millimeters. And so that is the way surgeons have to, bend the rules in order to get surgeries done. Otherwise, if we stick to 2.1, 2.15, so then we will, so ultimately it's we have to discuss with the patient. Options are there, the guidelines are there, and what she wants in that particular setting is very, very important.
A quick question to you, doctor. The role of radiation after you have given neoadjuvant immuno and Sir has operated. Does anything differs? Because the patient is also going to get adjuvant pembrolizumab.
Triple negative as such is not an indication for adjuvant radiation therapy. If patient have any BCS undergone, even early breast cancer, patient will receive radiation therapy. In case triple negative and there is a close margin or positive margin, in that scenario, maybe in the early breast cancer, adjuvant RT is indicated. Chest wall RT after MRM.
The question is whether we can omit radiation in patients who achieve a PATH CR.
No.
In an era of de-escalation, would you omit radiation in a subset of patients who achieve a PATH CR?
No, sir. If a upfront node is positive, no, I will not omit the radiation, even though there is a PATH CR.
And is them recall phenomenon, maybe it's an adjuvant setting, does it applicable here?
Use mic.
Ma'am?
Yeah.
No, use a mic now.
See, we are going to continue pembrolizumab adjuvant setting, and you are going to plan for radiation. Okay, node was positive. How will it affect or?
Nowadays, we follow only hyperfractionation. It's just 15 more days. It's 3 weeks. I think not like a conventional thing which lasts for 5 weeks actually. And in case of node negative, we follow only the fast forward 5 days of radiation. I think that won't be a problem. Yeah.
That's you can tell to the postgraduates, we are moving into this type of era for radiation. 5 days first and 15 fractions, yes.
I stopped practicing the regular fractionation 4 years back actually.
And I think people are comfortable also with this. They finish and they go.
One thing maybe, Doctor, to Anita, because in, say, many other cancers, for example, lung cancer, you've saw the benefit of these immune checkpoints across all molecules, essentially,
Yes.
So pembrolizumab, Atizo, Durva, you've all had almost very similar positive PCRs, EFS, and even in the adjuvant space also it was. But somehow in the breast, other than this molecule, somehow no other molecule seems to have sort of done. And you did make, maybe in your talk, allude to certain subtle differences, but somehow it's not too convincing. What are your thoughts more on that? Like, why is only the and now that you have got a positive overall survival also, the 5-year overall survival is about better by about 6%. So any thoughts, madam, as to why this molecule only seems to sort of win over the others?
See, in the and other subsets of breast cancer, already we have either a receptor positive or the HER2. So definitely that big chunk of 80%, there will be no immunotherapy. Only the triple negative. Yes, pembrolizumab has been tried. Atezolizumab, results are plus minus. We don't know why, maybe the PDL receptor status. And also I told you, triple negative has 6 to 7 subtypes. And I think none of the data has been done separately on each subtype which the drug. Okay, and there's a subset of triple negative who do well, and there's another subset who do badly. I think further sub-analysis with more studies with the drug can bring in drugs like durvalumab is already there, atezolizumab, more studies are needed. Now we are just starting with pembrolizumab. And like you correctly said, anywhere, any malignancy, advanced, metastatic, failed, you give pembrolizumab. Yes, we get an excellent result, but breast, yes, maybe the biology is different. So many heterogeneous factors are involved in this. Dr. Veda, your thought process after the surgeon's talk.
So I think the concept now is neoadjuvant therapy, and initially it was just chemotherapy, and now immunotherapy has gained in growth in almost all of the TNBCs. But a word of caution, in TNBCs, at least the real world challenges that we face is, one is, node negatives, very small tumors, you can be clear about upfront surgery. And LABCs, again, clear about neoadjuvant therapy. When it is like borderline or operable TNBCs, again, cost becomes a big issue. There are two other things. Not all TNBCs are same. So recently we've had a couple of cases, like adenoid cystic ulcer is a kind of TNBC, and where you would not give chemotherapy. Is a kind of TNBC where you would not give chemotherapy unless it is node positive. So these are the special kinds of TNBCs that you have to be wary of. And sometimes core biopsy may not give you the actual image. And in fact, we had two other like low ER positive tumors which behave like TNBCs, and after 4 cycles of your AC, in fact, the size of the tumor increased and the patient actually demanded for surgery. And once we did the surgery, it was like the ER was 6 on 8. So you can always have a change in receptor status. You can have heterogeneity. And one particular patient had tumor clones, different tumor clones in the same tumor. So all these are things which you will face in the real world. But yeah, classical TNBC, it's going to be neoadjuvant chemo or immuno, followed by your surgery and then adjuvant therapy.
Just one more thing which doctor pointed out is the ultra low HER2. And that's one thing, because we have a drug now, trastuzumab deruxtecan. So, and that side they're also trying to do a detection of this tumor. So that has to be also kept in the triple negative. So all triple negatives may not fail, but if you have picked up the ultra HER2, then that's a different part of thing. Ultra HER2 is HER2 negative, but FISH is positive. FISH is positive. So please remove those subset and then we go for pembrolizumab, because in those tumors, this drug will not act.
Then should you have to test for all patients FISH test, even though it's HER2 negative,
Yeah.
because we are not practicing.
Yeah,
like
we are
that
not
generally.
doing. Many labs are also not certified to do. They also don't have the expertise, but it's from AstraZeneca. They are bringing in fact, Monday we have an international speaker in Chennai. We invite everybody. Okay, so they are coming. It's a pathology mainly meeting to discuss how to do it. Yes, if logistics are there, you are dealing with an affluent society like HCG. And other places where logistics are in place, don't forget to do a low HER2. low heart. Not for all. At least when I'm in the medical college, I will not do. But when I come for the corporate practice differs with the patient population in India. I think Arvind will do only for a few cases.
No, I think slowly this concept of low and ultra low is coming up in a very big way, and I think that's mainly because there is a therapeutic benefit of the thing, and it. No, if you see in the last year, in the year in review when we had, sometimes we don't really know. Even the low ER, they seem to benefit from your endocrine therapy. So if you sort of read through the literature, it's so confusing. The sense like what people thought was low ER was akin to triple negative. But if you see in the latest thing, in the editions in the last year publications, they say even in the low ER, there seems to be a benefit of endocrine therapy. And in fact, it was a very significant benefit. Of course. And you, as you rightly said also, like, the other category of triple negative is the metaplastic carcinomas. Even metaplastic carcinoma, they don't. In fact, we have a publication from our institution also. They don't seem to be benefiting from chemotherapy. In fact, chemotherapy sorts of, was detrimental. So it's, as Madam said, I think we need to sort of, at triple negative, are various buckets, 5 to 6. In fact, we are trying to do one small study in the triple negative space also to look into which of these things are there. Any thoughts from the MSD side? Like, I just want your perspective, Dr. Sujit, on this.
For us also, sir, even immunotherapy, we are focusing beyond TNBC. One of the keynote is 756, where pembrolizumab is being evaluated for HR positive, HER2 negative. That trial also showed the significant difference between the PCR, around 25% PCR for the pembrolizumab arm, though it is much lower than the TNBC PCR rates. And when they evaluated the ER low category, the ER low subpopulation, the PCR was 45%. So from that perspective also, whether the ER low is actually working similar to the TNBC, because keynote 756 also highlighted in the ER low HER2 negative, there is a significant PCR benefit by pembrolizumab. So definitely there is and the 756, even my question was the same, that the role of immunotherapy, whether in the HR positive and HER2 negative, and what's the burden and what's the unmet need and what the faculty looks at it right now. And as you highlighted, Doctor, that the ultra low HER2, that will also change the future paradigm now, how the ADCs are also being evaluated, because we also have a pipeline from MST, which is SAC-TMT, which is a ADC, sacituzumab tirumetecan, and again being evaluated for advanced HR positive, HER2 negative trial. Recently also, Doctor, like 2 days before even TNBC and IIT Madras NIMBS, there is the paper was published, and that paper also evaluated the genomic alteration in HR positive, HER2 negative trial, and they highlighted the mutational, which are the difference mutation occurs in Indian population. So again, like lot of evolving data, but from pembrolizumab future perspective, sir, we already have keynote 756 for HR positive, HER2 negative, showed the significant benefit even in that population.
So use across the table. Use it for everyone.
And also, when there is low ER, when the Chi-67 is 80-90%, most of the tumors behaves like a triple negative only, especially when the Chi-67 is high.
No, I think all this mandates standardization of reporting, pathological reporting. And that's why a lot of these centers, they follow the CAP guidelines. And even in the ultra low, which Madam was alluding to, there was a difference